Guys, welcome back to Dental Pathshala. This is Dr. Sangeeta, prosthodontist or implantologist, here with you for another lecture of express revision course for complete denture for various competitive exam. So till now we have already covered the 3 parts of complete denture. I hope that you guys are enjoying and watching these express revision course, and it is for your competitive exam so that you can excel it in short duration of time, or it is for your revision for the exams. So talking about the tissue conditioners, but before we get started, make sure you subscribe to the channel. 60% of the students have not subscribed to the channel and yet watching the videos. So please do subscribe to the channel before we get lost into the video, and click on the bell icon so that every time I release a new lecture you get notified on your phone. So talking about tissue conditioners. Tissue conditioner is made up of polymethyl methacrylate. Methyl methacrylate we know, right? So polyethyl methacrylate. So this is polyethyl methacrylate. So PEMA plus ester or alcohol. Polyethyl methacrylate plus aromatic ester or ethyl alcohol. Now, because it contains alcohol, then there is a drawback, small drawback. We know that always alcohol has got drawbacks. Whenever a person is a drinker, always they have increased risk of cardiovascular diseases like that. So we know that alcohol is not good, right? So this tissue conditioner, what do we have? We have got powder plus liquid, and it combines to form a gel. Now when we mix this powder and liquid, we put it on the denture, and then we put that denture in the patient's mouth. So based on that, we have got 2 kinds of liners, 2 kinds of tissue conditioner. One is the short term, wherein this tissue conditioner we have to replace it frequently. How frequently we have to replace it? So this short term liners, intraorally they can stay up to 30 days, that means up to 1 month. But the long term liners we have got are used for the long term purpose. So they can stay more than 30 days intraorally. And the minimum thickness of a tissue conditioner which is applied on the denture base, it should be minimum of 1.5 millimeters layer of the thickness. Then short term, talking about the short term soft liners or the tissue conditioners. So we know that these short term tissue conditioners or short term soft liners, they are to be replaced within 30 days. So where these short term liners or tissue conditioner are used in case of ill fitting dentures, wherein because of the ill fitting or because there is overextension of the borders, there is some irritated tissues or there is some abused tissue. So in that case, it is going to provide a cushioning effect. The purpose is that it is, it is like a soft gel. So whenever the denture is, this is the tissue surface, and whenever the denture is sitting on the tissue surface, there are some pressures which are coming on the tissue surface, right? So what we are doing actually is, we are placing this tissue conditioner so that there is a cushioning effect which is present. So this tissue conditioner, they act as shock absorber. So they are going to absorb the shock because they are gel. But why do we call it the short term soft liner? Because they are used for short term purpose. Then why short term purpose? Why not long term purpose? What is the difference? These short term liners, they have got alcohol, right? Alcohol, and they have got aromatic esters as the plasticizers. So these alcohol which act as the solvent in case of short term liner, and the plasticizers which is in form of aromatic esters, dibutyl phthalate. Plasticizer, we know that every time whenever we are reading the dental materials also, we know plasticizer is the dibutyl phthalate. So once you remember it, you don't have to remember it again and again, and one way you can remember is phthalate starts from P and plasticizer also starts from P. So both of these things, the alcohol, the aromatic ester, they leach out with time. So when they leach out with time, that is the reason that they are of short term. That means when they leach out, then the tissue conditioner, the effect of tissue conditioner is not that great anymore, so we have to replace it. So where do we use these short term tissue conditioners or the short term soft liners? One, in the impression, so functional impression we use it. The functional impression, if we talk about the Winkler functional relining method, so functional impression, we use it as a functional impression material. So we are going to take impression from the tissue conditioner. That is why this is an impression material, and in the impression material also we have studied this. And second one is act as a temporary lining of the immediate dentures. Now immediate dentures are the dentures which we are giving immediately after the extraction. So what we are doing is, suppose if a teacher comes to you for denture and she or he has got few teeth in the oral cavity now, but they do not want to go completely edentulous, or there is some entrepreneur, there is some speaker or some teacher, singer, all these people, they cannot work without teeth. So what they want, they'll come to you and they'll ask that we want the tooth, we want the denture immediately, we don't want to go for without teeth. So in that case we give immediate denture. Immediate word means immediately, that means on the spot, right? So whenever we are giving immediate dentures, we are removing the teeth, that is we are doing the extraction, and immediately we are giving the denture. Now this denture is going to hurt the unhealed or the traumatic tissues. So for that purpose we are giving the short term soft liners, because we don't want that patient to be hurt or patient to be in pain. So in that case we are giving temporary lining material, temporary lining of the immediate dentures. So we have got some soft liners. So one is Koi Comfort tissue conditioner, which act as a tissue conditioner itself. So that is we use for ill-fitting dentures. Then we have got Hydrocast. Cast, see, as you can say, cast word is there, hydro water word is there, that means it is used as the functional impression material. Then we have Monoplast B. Monoplast B you must have seen in the labs. So Monoplast B, we use it as a permanent soft relining material. So if you want to do the relining of the denture base, that means if the patient comes to you and the patient has got ill-fitting denture, loose denture, in that case when you are doing the relining procedure, and in case it is traumatics, then you are doing soft relining. So it is a permanent soft relining material. Then the Permasoft from Dentsply. So it is soft, right? Permasoft. So this is used as a soft relining material. Then we have got Viscogel. Viscogel. It has got gel in the name. So it is used as the tissue management. Then we have got Versasoft. Versasoft, we know that it is a soft material. So it is used in the preparation of making the silicone denture. So it is a material of choice for silicone denture, for soft liners, right? So these are some examples of soft term soft liners or tissue conditioners. Now talking about the long term. Long term tissue conditioners or long term liners. See, these are given for the long term purpose, For example, wherein the patient cannot take up the stresses of the denture, wherein the patient cannot tolerate the stresses due to denture. In case patient is having chronic pain, soreness due to denture, discomfort, or there are sharp ridges, sharp severe resorbed ridges, severe sharp thin bony resorbed ridges, in the ridges if deep undercuts are present. And when the patient is having xerostomia, then also we give the long term liners. If the patient is having bruxism habit, because that way the loads are more, right, because the patient is doing the parafunctional habit, so more load is there. So the material for long term liners can be acrylic, which is the plasticized, or it can be the silicone material. Again, silicone material can be again heat cured or chemically cured, like how we have acrylic, right, or the chemically cured. See, both of these materials, the acrylic, the silicone material, both of these material, the initiator in both of these is benzoyl peroxide. Is the initiator. So next comes the difference between acrylic and silicone. Now what is the difference between acrylic and silicone material? Acrylic material is a hard material, silicone material is a soft material. So acrylic is a hard material, silicone is a soft and elastic material. Silicone is not like, if you have seen any maxillofacial prosthesis, then that is most of the times it is made up of silicone material, so it is soft and elastic. If you have seen ear prosthesis, eye prosthesis, all these prostheses are made up of silicone material. So acrylic is less resilient, we know that, and the silicone is more resilient. And also the acrylic, it makes a good bond with the denture, because already this denture is made up of acrylic, so it makes a good bond with the denture. But on the other hand, the silicone makes a low bond strength, it has got low bond strength. And also acrylic is hard, so it has got better abrasion resistance. Abrasion is in the winter seasons, now that winter are coming, and if you scratch with a nail your skin, so there a line will come, right. So suppose this is your hand, now you will be like 1 2 3 4 5, okay, 5 fingers, fine. So if you are trying to scratch with a nail, then a scratch will come, right. So that is a abrasion. So if you are trying to scratch this acrylic, the scratch won't come. But on the other hand, the silicone is a soft material, it is elastic material, we know that, so it has got low abrasion resistance. Then the most important point, then you will be like, ma'am, why do we use this acrylic material at the first place when the silicone material is so good? Why don't we use silicone all the times? Because silicone material is more susceptible to candida, more susceptible to candida. So chances of having candidiasis is more with the patient wearing silicone prosthesis, and the chances again for acrylic it is less. So talking about denture adhesives. Denture adhesives are used for well fitting denture. I know that you people give the denture adhesive in case of ill fitting denture. Now let me tell you something, that what are the contraindications? I will write contraindication as well. So what are the contraindications of denture adhesives? Contraindication, it is contraindicated in ill-fitting denture. You must be surprised to know that. We don't use denture adhesive in ill-fitting denture. We do the relining procedure for ill-fitting denture. We do not give adhesive and send the patient. Until and unless you don't know the relining procedure, then also you don't do it, because you learn relining procedure. Or you can, if you don't know at all, then you can, if the patient can afford, you can make one more denture. So, denture adhesive is given for well-fitting dentures, or moderately fitting also you can give. Right. So, why well-fitting denture, you must be asking, ma'am, why do we use for well-fitting denture when already the denture is fitting properly? Why do we need a denture adhesive? Denture, basically what is denture adhesive? Denture adhesive is a glue, so that the denture sticks to the tissues, right. So, in case of a new denture wearer, when the patient is not used to wearing a denture, in that case, for few days you ask the patient to use the denture adhesive. And also, where do we use this denture adhesive? We use it while recording the jaw relationship. So, to stabilize the trial bases. So, basically trial bases are our denture bases with the occlusal rims, right. And then we also use this denture adhesive in case of handicapped people, in case of people having poor muscle tone, because the muscle cannot hold the prosthesis or the denture. So, that case, in poor muscle tone also we have to use the denture adhesive, for example, if a person is having Parkinson's disease and all. So, where this denture adhesive is contraindicated? We know that in a case of ill-fitting denture, we cannot give denture adhesive. Also, because in that case, we are going to do the relining, right. Also, in case of worn out dentures, the reason is same. We should not be using this denture adhesive for worn out denture. Instead of that, the substitute to it is a relining procedure, or also you can give a tissue conditioner. Or it is contraindicated in people taking medication inducing xerostomia. So, all the medications which are causing xerostomia, first of all, when a patient comes to you with a xerostomia, the very first thing is you diagnose the xerostomia at the first place. Once you diagnose it, it is the shiny, the oral surface, oral tissues are very glossy and shiny, and once you place your finger, it is going to stick to the tissues. Suppose if anything is dry, it is going to stick, right. Suppose if you have bought new leather cover for sofa or for car, so sometime what happens, or you are traveling in a train, sometimes what happens, if you try to touch with the hand sometimes try to stick with the new leather, right. So, that way the finger is going to stick to the oral tissues. So, first of all, the first thing is you diagnose the xerostomia, then you know what is the etiology of the xerostomia. If it is medication induced, we cannot give denture adhesive, right. So, the denture adhesive, how does it work? The second thing is that, suppose this is a denture adhesive. What is its property? That it sticks to the tissues, right. So, this denture adhesive has got anions. And what it does, in the oral cavity, we have got saliva, mucous membrane. So, in the saliva, mucous membrane, there are some cations which are present in the mucous membrane, right. So, these cations, they combine with the anions present in the denture adhesive and it produces stickiness, right. So, these denture adhesive, they have got a property of water absorption. They are going to absorb the water. And if you have noticed, what do? If we are using the powder denture adhesive, then we spray little bit of powder, we sprinkle, I must say, we sprinkle little bit of water, a little bit of powder. Suppose this is your denture, this is the tissue surface of the denture, and we are going to sprinkle little bit of powder on the denture surface, and then we put it in a water bowl, right? Then we put it in a water. Then we put this in water, and then what happens? This denture adhesive, it swells up. So it has got a property of water absorption. We know that it swells up. So in the presence of water, it is going to swell up to 50 to 150% by volume. And the adhesion is due to carbonyl group. So for example, synthetic salts of dentures. So you can remember G for dentures and G for gum, right? So guys, what is relining technique? Relining technique is wherein you are going to resurface the tissues. The tissue surface, the denture is ill-fitting, denture is loose, so you are going to resurface the tissue surface of the denture. It can be done in two ways, one open mouth, another is the closed mouth. So open mouth, you are going to separate both the impressions. Closed mouth, you are going to take in occlusion in together, both upper and lower at the same time. So when you are doing the open mouth, the previous denture, the patient's previous denture, you are using as a tray, and then you are making again new centric relation record, all the procedures you are doing again in one appointment. So coming to next one we have is the immediate or the interim denture. Now interim or immediate denture, we use it in the patient whom there is a aesthetic main concern. So there is no need to go without the teeth. So when the patient cannot go without the teeth for a single day, or we use in case of periodontically compromised patient. So what happens when we are doing extraction at the same day, immediately after extraction, we are giving the denture. So you are extracting the teeth, and immediate dentures, I have made a separate video, you will find in the playlist of complete dentures in one of my lecture series. In that you will find separate lectures on immediate denture if you want to learn in detail about the immediate dentures. So what do? Immediately after extraction, there is a series of extraction. How do you go? So immediately after you do anterior extraction, immediately you are going to give denture to the patient. This denture we call it the immediate or the interim denture, and once you insert the denture, it should not be removed. Should not be removed for 24 hours. So you are asking the patient, if the patient is having discomfort or anything, the patient is not going to remove. You are going to recall the patient after 24 hours, and the occlusal adjustments is done after 48 hours to the 1 week time after the insertion. So after you have inserted 48 hours to 1 week, after that you do the occlusal adjustments in case of patient with the immediate denture, right? Next comes the forces. So the forces of the jaw, what is the masticatory load? Or we can say the biting forces, right? So for natural teeth, we know that natural teeth can take up more load. We can eat almonds, we can chew so many things, chicken, so many things, right, from the natural teeth. So it can take up to 20 kgs of load. The natural teeth can take up 20 kgs of load, or we can say 44 lbs. So lbs you can actually somewhere close to, if you multiply by 2, it will somewhere become close to this value. Then for the CD, the masticatory load is only 6 to 8 kgs, that is 13 to 16 lbs. And the maximum occlusal forces a patient can take up for average denture patient only 50 psi, and for dentate patient with teeth, 150 to 250 psi. I am sorry, 250. So how do we measure this maximum force of the jaw? We measure it by a Boo's biometer. It measures the maximum forces of the jaw. So one more thing I want to tell you is the swallows per day. So how many times we swallows per day is 600, unbelievable. And total amount of periodontal area, PDL, periodontal ligament area in each arch, per arch, it is 45 centimeter square. Okay. And most common, let's talk about the most common things. So the most common fracture of the denture is the maxillary denture fracture, that too the midline fracture. So if they ask the most common fracture is the maxillary denture fracture, the most common cause, the most common fracture in the maxillary denture is the midline fracture. Then the second most common fracture is the mandibular denture fracture. And in the mandibular denture fracture, the most common cause of mandibular denture fracture is the accidental dropping of the denture. And the second most common for mandibular denture fracture is the poor retention of and the poor fitting of the denture. Right. So talking about the separating media, the most common separating media is our cold mold seal. The pink color one which we use it all the times, which is our sodium alginate, right. So sodium alginate or cold mold seal, it is composed of, which is the most common? It is composed of sodium alginate, 2% in water, then sodium phosphate, glycerine, alcohol and water, preservative, right. So what is the reaction? Sodium alginate plus calcium which is present in gypsum product. Now one more thing I want to tell you is, whenever you are doing the processing, sometimes the mistake the students does is they apply separating media on the wax also. Now understand this, that we are talking about the setting reaction of the cold mold seal, right, and when it combines with the calcium, then only it forms an insoluble calcium alginate. Now if you are applying cold mold seal on the wax, what will happen? This reaction will only not occur and the membrane will also not formed. So this insoluble calcium alginate forms a membrane. So what are the other separating media which can be used? The most common, of course we know that it is cold mold seal, then tin foil, So, other separating media, tin foil, also we know that cellulose, lacquers, calcium olate, sodium silicate, starch, starch we use in impression plaster. Then we also use evaporated milk and also soft soap. So, these are the other materials which can be used as the separating media. And also one more thing, denture cleansers. What are the denture cleansers? Used for cleaning the denture, as the name suggests. So, they can be sodium perborate, can be alkaline peroxide, or hypochlorite. We know that hypochlorite is most of the time used for cleaning only, right. So, these are the denture cleansers. Now, talking about the last topic in the complete denture in today's video is the denture stomatitis. So, denture stomatitis is also known as denture induced stomatitis. See, as the name suggests, I always tell you to break the term to understand the term better. So, denture stomatitis, denture means denture, stomatitis means, stoma means mouth, itis means inflammation. That means a patient is having inflammation of the mouth due to the denture. So, the other name can be denture induced stomatitis, denture sore mouth, inflammatory papillary hyperplasia, or chronic atrophic candidiasis. So, it is seen in 50% of the denture wearer. So, 50% of the denture wearer actually get the denture stomatitis, and according to Newton, it is classified into 3 types. This is from the Boucher itself. We have also covered this in the complete denture lecture series. You will find in the playlist, if you search in the playlist complete denture lectures, you will get in detail video about everything. So, the type 1 is the localized. So, in the type 1 what happens is, there is a localized simple infection, okay, and in that there are only pinpoint hyperemia, So, you will see that there are only pinpoint hyperemia which is present, that too only in the localized area, in the specific area. Then the second one is the erythematous type. In the erythematous type, as the name suggests, there is going to be redness. So, more diffused erythema is there. So, you will see that there are more diffused erythema. So, this is a generalized simple type. Then the third one is the granular type. And this will be seen in the alveolar ridge plus central part of the hard palate, right. Now, this localized or type 1 is the trauma induced, while type 2 and type 3 are microbial plaque, due to microbial plaque accumulation. And denture stomatitis is also seen along with the angular cheilitis. That is, you see at the angles of the lips, right. And also, where also we have studied this angular cheilitis in the vertical dimension, right. What do, if you reduce the vertical height of the patient, if you reduce the vertical dimension, what will happen? The folding will come, and in this folding saliva will start accumulating, and because of that the angular cheilitis will develop. So, guys, last one point is the combination syndrome. We also call it the Kelly syndrome. right, because it was given by Kelly in 1972. Now, this combination syndrome is seen when there is a maxillary CD, because mandibular anterior are the last teeth to fall off. So, rest all the teeth will go, only mandibular anterior will left. So, due to this reason, the maxilla, the patient will have a CD, mandible, the patient will have RPD, and because of that the combination syndrome will be there. So, because of that there is going to be flab, the resultant to that is the flabby tissues and all this, and the mandibular distal extension, RPD, right. So, guys, this finishes the complete denture express revision course for you guys. All the very best for your competitive exam. I know that you are going to rock the exam, you are definitely going to score good marks, but the most important thing in the life is that, okay, that was my phone. So, I know that you are going to rock it. The most important thing I was telling you in the life is that it's not about clearing the exam. Nobody after this, after your MDS, after your BDS, nobody is going to ask you how many marks you scored. The most important thing in life is that what do you learn out of your books, and that is the most important thing, because we call ourselves literate, we call ourselves educated, but we never pay attention to what we read in the books. What we read in the books, we don't apply it. So, I want you to apply all the things I have taught you in your clinical practice. So, whenever you are reading something, you should pay attention that part when the patient comes to you, you are going to remember this. So, this is the reason that we keep on revising it. So, I hope that you guys are now clear with the complete denture lecture series, complete denture express revision course. I have tried to cover maximum of it, most of it, and I wish you all the very best for your competitive exam. So, if you have enjoyed the video, give it a thumbs up. Also, you can comment in the comment section below if you have enjoyed the video. And guys, have faith in yourself. I have faith in you. You also have faith in yourself. Take care. Bye-bye.